Hey guys, let's go a quick revision on gestational trophoblastic neoplasia. Okay, we all know after mole, it can convert into cancer. So half of the moles are converted into cancer, one-fourth of the abortions can convert into cancer, and one-fourth of term pregnancies can convert into cancer. That is GTN. Okay, I already told in previous video, like if in 2 weeks HCG is more increasing 10% or plateaus, or 6 months after also HCG is coming positive, and HP histopathology of the tissue showing choriocarcinoma features, then it is known as gestational trophoblastic neoplasia. Okay, gestational trophoblast also occurs after non-molar. See, if it complete mole, it can become 15 to 20% of GTN, but sometimes non-molar like abortion, simple pregnancy after also they can become GTN. So what are the symptoms? So that lady just got delivered, she's saying that she's having persistent vaginal bleeding. Even after her loop, everything is completed, but persistent vaginal bleeding is there. Fecal uteruses are there, okay? And the subinvolution, we can palpate the uterus even after 3 months also, okay? Asymmetrically, uterus is enlarged. HCG, if you done, it is increasing. Sepsis is there. And metastatic features, like if lungs are involved, then you can see the cough, shortness of breath, pain in the chest, hemoptysis. Why I'm telling about lungs? Because 80% of lungs are involved, okay? 80% of times. Sometimes vaginal metastases are seen 30%, pelvis is in 12, 20%, brain 10%, liver 10%. These are different types of mets which are seen. So different features will come even after normal delivery, okay? Even after normal term pregnancy, then you should suspect GTN, okay? Invasive mole, it comes after molar pregnancy. Okay, so so from childhood onwards, we learn that invasive mole, choriocarcinoma. So both are different. Okay, invasive mole comes after molar, whereas choriocarcinoma comes after non-molar pregnancy. Okay, so invasive mole comes after molar. It is also known as gestational choriocarcinoma, invasive mole. Okay, here the chorionic villi is seen. Whereas normal choriocarcinoma is sorry, invisible after molar pregnancy. Gestational choriocarcinoma is after any term pregnancy. Okay, it is seen after in 1 in 40,000, and villi are absent here. And gestational choriocarcinoma has poor prognosis. Coming to PSTT, PSTT is seen about 1% of cases. Here you have a mononuclear intermediate trophoblastic cells and white tan-like structure seen mainly on the posterior wall of the uterus. Your cells have hypochromatic nucleus and dense eosinophilic cytoplasm. Villi are absent here also. Okay. Here the tumor marker is not HCG, it is human placental lactogen. Placental alkaline phosphate also increases. Proliferative index is high, 10 to 30%. Surgery is needed. Then endodermal, sorry, epithelioid trophoblastic tumor. This was also less than 1% here, or same like PSTT, but only the white tan one is seen in the lower part, okay, in the cervix and all that area. HCG will be low. Staging is confined to the uterus is stage 1, other one organs is stage 2. If lungs are involved is stage 3, this is an important question. Then distant is stage 4. Now coming to FIGO classification of scoring, there are 8 points. First you write 0, 1, 2, no 3, okay, only 4. So first in 8 points is age. Age, if it is less than 40, like 39, then 0 score. If she's 40, then it is 1 score. Previous pregnancy is MAB. MAB is molar, is 0. Abortions is 1. And term birth is 2. Beta is 1,000, 10,000, 1 lakh, more than 1 lakh, more than 10 lakhs. Okay. Coming to what is this? Months. Interval between the pregnancy and landing in GTN is 4 months, then 4 to 7 months, then 7 to 12 months, and more than 12 months. If size is less than 3, size is, let's say it is 4 now, so it is 3, then 3 to 4, then 5. Okay, mets, I already told, most common is lungs. Then after that you go down, so kidneys and liver. Okay, or down, that is intestine. Then sorry, kidneys and spleen, sorry. Then intestine. Then you go for liver and brain is 4. Coming to metastasis number, like if 1 to 4, 4 to 8, and more than 8. Okay, and previous chemotherapy 1 and 2. These are scorings. If it is less than 7, then it is low score. The single chemotherapy agent is given. Okay, generally we'll prefer actinomycin. The methotrexate also can be given. Methotrexate day 1, 3, 5, 7, and alternatively we'll give folic acid. Methotrexate 50, folic acid 15. Okay. GTN after chemotherapy, you'll do beta HCG when? two weekly. Okay, like in molar pregnancy, you remember when you will do? You'll do every weekly. Yes, and you'll do every weekly until it becomes normal. After it becomes normal, then what you'll do? You'll call her and do after 6 months. Okay, right, right. Yeah? Hmm. So after suction and evacuation, you do weekly, okay? Whereas in GTN, you will do two weekly. So GTN is a condition where it is obsessed with the word two, okay? So two weekly you do. Actomycin D is 1.25 milligram per meter square. You'll give every two weekly again this also. So 7 to 12 if it is it is known as high score. Okay. Here you'll give Imaco. First you write Imaco and make a into of M. You just scratch it off M. So I'll tell you. So first day one is you'll give EMA. That is EMA. Etiopide, it, etoposide. Okay. Etoposide etoposide you'll give 100 per meter square IV. Whereas methotrexate 100 plus 200 IV. Actomycin D 0.5. Next day 2 you will give imana. So you scratched M na. So E and A you'll give. Folic acid will also give. And day 8 you'll give coke. That is cyclophosphamide 600 and oncoven that is vincristine 1 milligram per meter square. This is high risk. If more than 13 or 13, then it is known as ultra high risk. Okay, here there will be collapse, multi-organ failure, septicemia. Okay, so you'll start gentle chemotherapy. Like day one you give etoposide and day two you give cisplatin. After that you will start the immunotherapy. Pembrolizumab also can be added. Pembrolizumab. Okay, in case of brain mets, you can give intrathecal methotrexate 12.5 milligram. Okay, if a lady GTN, she got treated, now she became pregnant. Okay, after delivery, you send the placenta for histopathological examination. Okay, it's about brief on GTN. Thank you.